Hi. Here you go. Good evening, everyone. Sorry, Chris.
Yeah.
It is 6:30, so we're going to start 6:30 sharp. I just wanted to quickly introduce you to our host this evening. Thank you very much, Prof. Chris Hendricks, for hosting the session. And then the speaker is Dr. Bertram Henderson, who will be introduced by Prof. Chris now. And then just thank you to Takeda for the sponsorship of these presentations. We really appreciate the buy-in. And then if you have any questions, please feel free to ask your questions in the Q&A or in the chat box, and we will get to that afterwards. Thank you very much, Prof. Chris. You may continue.
Good evening, everybody. Hope you're having a great day, and lovely to see so many people online again. And I know to some extent, some of you may think, what a repetition of Fabry disease. But actually, I want to introduce you to Bertram Henderson, which I think many of you will know. He's been around many, many years. And most of you will know him as the head of the clinical genetics units previously from Bloemfontein, Orange Free State. Now living much closer to the sea, Mossel Bay, and being involved in private practice there. But what he brings is a wealth of expertise in this field of medical genetics and these rare disorders, with multiple publications, presentations, invitations in this field. So I think it's really important that we've had a lot of talking about Fabry disease, but it's really important to have some local cases and some input from the local expertise and how it all builds up. And as you will see again, Bertram will bring a completely new perspective. So I will encourage all of you who may have missed some of the others not to dash off, but please stay on and listen to Bertram, and we'll have a Q&A at the end. But you may want to look at the whole series, because each and every one of the people speaking brings a different perspective. And with that, I'm going to go off camera and leave it over to you, Bertram, until we get to the Q&A at the end.
Thanks very much, Chris, for those kind words. And thanks to Ilse and Elnay for inviting me and organizing everything here. Good evening, ladies and gentlemen. It's a privilege over here for me to speak about Fabry disease. I'm going to do a bit of basic sciences, which I find helps me to understand Fabry better, and then go on with the two case studies. Fabry disease, also called Anderson Fabry disease, is actually a challenging, complex lysosomal disorder. And because of the nature of Fabry disease, and it's called the Great Masquerader, and I'll make that clear later. And I also hope that I meet the standards set by the previous speakers in the series. These are my disclaimers, and the presentation today is my own work without any input from the sponsors. So my intention tonight is just to give an overview of lysosomal function, lysosomal storage diseases, and then after that I'll go into Fabry disease, speak about the genetics, the inheritance, but prevalence, and then use two case studies, one to emphasize the importance of a family history, and other just to show how complex it can be sometimes. And I'll try and just indicate the variability as well. And then we'll have some time for questions afterwards, which I hope I'll be able to answer. So I'm sure you're all well aware of this image of the cell and all the organelles in the cell. And so we've been concentrating on the lysosome for a while now. And the lysosomes are intracellular vesicles containing a wide variety of more than 50 glycoprotein hydrolytic enzymes that serve to digest and expel exogenous material, including bacteria, other cell waste from the cell. And the lysosomes really actually function as the recycling unit or recycle system of the cell. So it both degrades material taken up from outside the cell, as well as obsolete components of the cell itself. And these enzymes then hydrolyze proteins, DNA, RNA, polysaccharides, and lipids, and make the building blocks of those molecules available for the synthesis of new proteins, etc. The lysosomal storage disorders is a family of more than 40 different diseases, and they're all due to a genetic defect resulting in the absence or a deficiency of one of the lysosomal enzymes. And because of this deficiency, the substrate accumulates and the lysosomes become engorged and then disrupt cellular function. Each of the diseases is different because of this substrate and the organs in which it accumulates. The other characteristic of the lysosomal diseases are they're all progressive. And as they progress, the damage becomes irreversible. Double click, sorry. So over here we'll see an image of a normal substrate degradation and expelling out of the cell. But with an LSD, the lysosomes accumulate the substrates because they can't break them down. And as they become engorged, there's just a disruption of cell functioning, eventually leading to fibrosis and cell death. This is a busy slide, but it shows the relative incidences of the LSDs. Those that I've labeled in red are LSDs where there is specific enzyme replacement therapy available. On the international figures, Fabry is actually the second most common LSD. In South Africa at the moment, we're finding that Hunter's syndrome is actually more frequent than Fabry disease. But I think that might be an ascertainment bias, or maybe there's something in our genetics. The incidence of Fabry disease is estimated to be 1 in 40,000 men and double that in females. Some of the recent newborn screening programs have suggested that Fabry is more common, and I found one that even claimed that the incidence was 1 in 1,400. Quite a few of these studies are based on genetic studies only, and as you see when we come to the interpretation of the genetic results, it might be an overestimate. The variable and non-specific nature of the early symptoms make accurate incidence estimates quite difficult, but there's a massive body of information about genotypes and it's growing steadily. So genotype-phenotype data is increasing, and we can use that in deciding about whether to label the patient as having Fabry disease and also which treatment and when to initiate. Fabry is pan-ethnic and occurs in all our population groups. Premature death is frequent in Fabry disease. And once we've identified Fabry in a family and we embark on proper cascade screening, we will probably find between 5 and 8 other individuals that also have Fabry. So it's quite important, the family history. Fabry is due to a deficiency of an enzyme called alpha-galactosidase A, or abbreviated to alpha-Gal A. Now, alpha-Gal A is a homodimeric glycoprotein encoded by the GLA gene, which is located on the long arm of the X chromosome. And then the deficiency of the alpha-galactosidase will result in GB3 and GL3 accumulation in the lysosomes. Without alpha-gal, the galactose at the end of the sphingomyelin molecule can't be removed. And if that galactose is not removed, the rest of the molecule cannot be metabolized, and then the GL3 will accumulate. And the cells where it accumulates in particular is vascular endothelium, cardiomyocytes, podocytes, and the dorsal root ganglia. But it accumulates in all other cells as well. So the most important is that it's the loss of the first step in the whole process of metabolism that causes this disease. This is a busy slide. I think the biochemists will appreciate it quite nicely. It just shows the whole sequence of events in the lysosome during the metabolism of sphingomyelin, and then all the different disorders that accumulate from the various substrate accumulations, depending on where the deficiency is. Fabry is one of the 3 X-linked lysosomal storage diseases. X-linked means that the location of the defective gene, or the gene itself, is on the X chromosome. Previously, we used to say that X-linked disorders are recessive or dominant, and recessive disorders only affect males and the females are carriers. Well, we know that what we taught previously was wrong. And that's why we've dropped X-linked recessive and we just speak about X-linked. So if the man is affected, there will be no male-to-male transmission. So all his sons will be unaffected, but all his daughters will have inherited the pathogenic variant from him and can be classed as carriers. But about 43% of the females will then be symptomatic. When the female is a carrier stroke affected, then there's a 50% chance that she'll transmit the pathogenic variant to her daughter and 50% to the son. So it's 50-50 for an unaffected son, and for a daughter or affected daughter 50% as well. So that's just basically, just in brief, the inheritance as it goes on. And the reason for this females being affected sometimes and not sometimes is due to X inactivation, which we'll speak about. There are over 1,200 GLA variants that have been reported in the various databases, and all the different types of genetic changes are seen in Fabry, whether it's a deletion or a missense or a nonsense variant, whether it's a in-frame or an out-of-frame deletion, or a duplication in the gene. A number of these variants that have been identified cause classic Fabry disease, and quite a lot also have late onset or single organ involvement. And as is the bugbear in all genetics nowadays, we find a number of VUSs, which then just complicate decision making. But as more information is gathered and obtained, we sometimes can reclassify the variants. The same as these variants over here, which on this old slide, if you can read at the bottom, you'll see it's a 2018 slide, or article, all these were considered to be benign variants, which we know now that in particular these two are late onset milder variants. So if we look at Fabry as an LSD, it is genetic as an inherited enzyme deficiency. It affects numerous systems and organs. It is progressive, debilitating, and life-threatening. But not only that, it's variable between and within families. So it is really a good example for taking a good history and asking the question, are these complaints stroke organ involvements part of a single disease, or are they different? Have they got different causes? This slide then just indicates the progression of Fabry disease, the acroparesthesia, which is a peripheral nerve involvement resulting in burning sensation in the hands and feet particularly, starts at a very young age, progressively gets worse, and then sort of almost gets burnt out. And all the other organ involvements start at different ages and get progressively worse. And when we look at quality of life, you'll see as the constitutional symptoms get more, the quality of life decreases. And the disease has got a big impact on the quality of life. We consider, as I said, classic and late onset disease presentations. Classic Fabry in males has got an early onset, first or second decade of life with multi-system involvement. Classic Fabry disease in females is variable in terms of expression and age of onset. And then we do have late onset variants presenting from in the 4th to the 7th decade, renal only, or even with more commonly a cardiac only phenotype, which may be considered a attenuated variant. So the classic females vary between asymptomatic, milder, later onset, right through to having a classic phenotype very similar to the males. And this, as I said earlier, is due to X chromosome inactivation. And 43% of heterozygous females will then have clinical symptoms. There are actually more people with atypical and late onset variants than people with classic Fabry disease. And the difference will be in that late onset variants have got 10 to 50% of enzyme activity, whereas all the classical variants have got less than 1% GAL-A activity. So if we go just looking for classic Fabry disease, we'll probably only be looking at the tip of the iceberg. I've got this slide in just to show how the disease progresses from a defect in the gene encoding for alpha-gal. So then because of that variant in the gene, we've got deficient or very low alpha-gal activity, and that results in accumulation of GL3 and other substrates in the lysosome, and they have actually already identified that this accumulation starts in the fetal stage. As this GL3 accumulates in the cells and also in the plasma, you'll get cellular disruption, vascular, capillary endothelial cells, podocytes, cardiac, nerve cells, and then tissue responses, cell injury will be initiated, resulting in fibrosis, cell death, sclerosis, and obviously once there is cellular damage, the whole process is irreversible, and we can only just offer symptomatic treatment. This slide is actually just showing you all the different aspects of inflammation that's involved in the immune inflammatory response leading to the fibrosis and the sclerosis. So this is just to indicate the disease progression. And as I said, there have been articles showing GL3 accumulation in the placenta of affected male infants. So we'll see that the GL3 accumulation at the bottom bar, then after a while there'll be tissue involvement and clinical symptoms coming in. Then after that, organ failure leading into premature death. This reduced life expectancy is actually quite significant in males and in females. Stroke in Fabry disease has been associated with a 76% mortality, but cardiac and renal failure all contribute to this significant reduction. Previous talks have shown all the different symptoms of and all the organs that can be involved. Heat and exercise intolerance with the peripheral neuropathy, and there's episodic pain crises, chronic burning pain, actually is quite significant in childhood. And this burning sensation is exacerbated by exercise, by warm weather, fever. So these children go about avoiding exercise or other precipitating factors. And they get called lazy or they're malingering when they've actually got early warning of a severe illness. They've often got hypohidrosis, which makes the ability to cool down limited, and they can then get unexplained fevers, and the exercise intolerance is even worse. GIT symptoms are quite non-specific, adding to this whole issue of having so many non-specific challenging symptoms, and makes it quite difficult for healthcare workers actually to put together that these are all related to a single cause. And then as we progress into adulthood, we'll find a similar pattern of symptoms. Because of the non-specific nature, a lack of diagnosis, no cause found, depression becomes quite apparent. And then there's decline in renal function, cardiac problems, and the peripheral neuropathy carries on. So as we age, all organ systems will be affected to a greater or lesser degree, causing increased morbidity and premature mortality. All right, so this is what we call a pedigree or a family tree, and this is a shorthand way of recording it. The square indicates a male and the circle a female. If at the top of the bar there's an individual marked 1:1 and 1:2, male and female. The line joining them is then the marriage line, and then the line descending from that line is the descendant line, which branches off into their children. And when there's a disease, symptomatic disease, we'll color the block in, and we'll have a symbol definition on the page as well. So this little boy at individual 5:1 had severe acroparesthesia. Fabry disease was identified, probably because the family was alert to the fact that his grandfather had died of Fabry disease at 54 years of age. So they were sensitized to that. And he was started on enzyme replacement at about 6 years of age. I met him at 10 years of age. At that stage, his aunt, individual 4-5, was already on enzyme replacement treatment because of her renal involvement and other involvement with Fabry disease. His mom then, at late 20s, early 30s, started developing angiokeratomas, and because we knew about that, we were monitoring her, and we found that she started developing albuminuria, and enzyme replacement therapy was treated. The younger sister then started complaining of fatigue, and as she phrased it, she said she's so tired that 2 or 3 times a day she'll sneak off into the toilet and have a 10 or 15 minute nap. She had such severe fatigue and also some other symptoms and that. So I'm not quite sure what's happened, whether she's on treatment at the moment now. And then as we got the opportunity, we actually found out more that the index case's great-grandmother had a sister who was symptomatic, had a sister who was symptomatic, had a son and a grandson who was symptomatic. The circle with the dot in is a female then who was old term a carrier. Apparently she had no symptoms. So this is really the extent that we see family involvement with slightly different presentations as well. When you get your genetic results, these are the type of reports that you'll get. So individual 4-5, her report was a heterozygous pathogenic variant. Heterozygous means that one of the 2 copies of the gene has been changed, and it's got a pathogenic variant, in other words, causing disease, GLA gene. The C dot refers to coding DNA. 402 means at position 402, in other words, base pair position 402 in the gene, there's a deletion of thymine, the del T. And the effect of this on the protein P dot means that amino acid tyrosine at position 134 has been changed, and there's a frame, and it's a frame shift because it's only a single base pair deleted, and that causes a premature stop codon. And this means then that the protein is actually reduced from the normal 429 amino acids to 134 amino acids, and will obviously not function properly. My index case, the individual 5-1 will then have a hemizygous pathogenic variant. He's a boy. He's only got one copy of that, of the GAL-A gene on the X chromosome, and the term hemizygous refers to that. So that's just a little bit about the genetics and how and the interpretation of the results. So Fabry can present to the nephrologists as a result of abnormal urine analysis, decreasing renal function, early renal function with focal glomerulosclerosis or fibrosis, progressive renal failure leading to end-stage renal failure. And obviously then for asymptomatic individuals in the family that have got the pathogenic variant, we need to do regular urine checks to see if they're developing albuminuria and doing a protein creatinine ratio, as well as renal functions on a regular basis. The cardiologists will predominantly see patients with concentric left ventricular hypertrophy, mitral valve prolapse, or premature coronary artery disease or dysrhythmias. Interestingly enough, the symptomatic females often have cardiac fibrosis before they develop left ventricular hypertrophy. So it's very important to identify the female patients early, because if they've got fibrosis as one of the first findings when they see a cardiologist, enzyme replacement therapy is not going to be effective. So again, we've just got a summary over there. And the left ventricular hypertrophy and hypertension are predictive of life-threatening cardiovascular events at a young age. I don't want to speak too much about the presentation to the neurologist. Dr. Ramaswamy is speaking next week, if I've got my dates correct. She's a neurologist, an excellent speaker, so she'll take you through all of this. But there's a wide variety, with acroparesthesia being one of the earliest presentations, tinnitus, deafness, TIAs, and early stroke in the neurology there. The peripheral nerve involvement can result in visits to a pediatrician because of the pain or the GIT symptoms. And all Fabry patients have got a combination of central, peripheral, and autonomic nervous system involvement. So it's ischemic cerebral small vessels, white matter changes, etc. She'll go through that. Gastrointestinal manifestations, even though they're non-specific, are actually quite debilitating. It begins in childhood or adolescence: diarrhea, abdominal pain, cramping, early satiety, poor weight gain, and they are really uncomfortable, and sometimes they can spend hours in the bathroom in a day. And it's probably caused by GL3 accumulation in the autonomic ganglia of the bowels or in the intestinal vessels. Dermatologically, you get these angiokeratomas starting in childhood or in adolescence and getting progressively worse, particularly around the umbilicus, dark red to blue-black lesions, which are non-blanching, and they'll also be then in the bathing trunk area. The hyperhidrosis we've spoken about. It's just a different image of these angiokeratomas, and they've been reported in 37% of boys and 66% of adult males. Eye features, under a slit lamp, the optometrist or the ophthalmologist might see these wall-like symptoms, like radiating like spokes of a wheel. And approximately 70% of affected boys and girls in a pediatric study actually did demonstrate these changes. Even though it's such an important finding, it doesn't affect vision, and so they don't present. Tortuosity of the retinal and conjunctival vessels, as can be seen in these two slides, are also quite frequently seen. Okay, so given these wide-ranging, sometimes non-specific symptoms, many of these symptoms can be mistaken for other genetic or other diseases. And this table then gives a whole long list of potential misdiagnoses, people looking for other causes or considering various things. And this is probably particularly will happen when the multi-system involvement is not appreciated or not identified. And then all these non-specific, unrelenting nature of the symptoms will then worsen the depression. The pain will often be associated with an ESR or a raised CRP, leading to false other diagnoses. And that's why we speak of a diagnostic odyssey. There are extensive delays from symptom onset to final diagnosis, and a mean of 15 years have been reported for both males and females. So it is really a debilitating diagnostic odyssey to get from the symptoms to a final diagnosis. But, blowing our own trumpet, I might say, if they've had adequate genetic counseling from a genetic counselor or from a clinical geneticist, then the variable nature and the symptoms will be familiar to the family, and they will then often be the initiator with the physician or the pediatrician by asking the question, we've got a family history of Fabry. Can this be Fabry? And my experience with the families is when they ask you a question like that, don't ignore it. Or with complex other diseases, the parents will go and spend how many hours on the internet, consulting Dr. Google, as much as we don't like that, but they'll spend far more time researching the symptoms and the problems present in the individual or the family, and come and ask questions if you've got an open relationship with them, and allow you to far more time than we can spend with them. So that's also the value then of the cascade screening. All right, so diagnosis confirmation. Symptomatic males with the classic disease will have less than 1% of enzyme activity. So doing an alpha-gal enzyme assay will confirm the diagnosis in those cases. The later onset ones will have a 10 to 50% enzyme activity, and it'll be a bit difficult to be quite sure, and then we'll need to go on and do GLA sequencing. This slide shows you can do it in plasma, in leukocytes, cultured skin fibroblasts, but nowadays we really tend to do dry blood spot analysis, and Dr. Opperman gave a very good talk about using the dry blood spot, how to collect the specimens, and that is probably the most stable when handled correctly. The females, even with fairly classic disease, will have low normal enzyme activity, and quite a number of them will have normal enzyme activity. So you're unlikely to confirm a diagnosis by doing enzyme assays in females, and I believe you should go straight to DNA analysis and sequencing the GLA gene. Right. So what happens with X chromosome inactivation? At the time of conception, there'll be one X from the father and one X from the mother. And as the cells divide, these chromosomes will then be carried on to the daughter cells. But around about 17 days of embryological development, most of one of these X chromosomes will become inactivated. And that inactivated chromosome will obviously be either from the father or the mother, the paternal or the maternal one. But all the daughter cells of that cell where the inactivation has taken place, that will continue with the same X chromosome being inactivated. So maternal X chromosome, all the daughter cells will have the maternal X inactivated, and the same for the father. So this is a random process. So in an ideal situation, it should be a 50-50 split between inactivated maternal and paternal X chromosomes, but it might be a 60-40, or it might be a 20-80 split. And that is why we actually find then that the females can be symptomatic. And then just to go back to the old second-year physiology, the X chromosome that's inactivated will be on the nuclear membrane, as called X chromatin nowadays, or those who in my generation would have been called the bar body. Okay, so those of us that have attended the whole series of lecture will be aware of the local testing that's available, with the collaboration between Sanofi and the Center for Human Metabolics at Northwest University. And they're using dry blood samples that they will then analyze for 6 common lysosome storage diseases, including Fabry disease. And as I said, Dr. Opperman's talk about how to collect the specimens has been done. I think I've stressed it enough, the need to diagnose Fabry early. The earlier we can diagnose it, the more effective our treatment interventions are going to be. If there's irreversible cell damage, we're not going to have any success. And this is really important because enzyme replacement therapy is readily available. And the burgeoning research into and availability of chaperone therapy, which works for atypical cases, depending on what pathogenic variant they've got, is really becoming more readily available. The cost and the inconvenience of ERT does actually necessitate accurate diagnosis and thorough investigation for organ involvement before embarking on enzyme replacement therapy. Okay, so I've done on the one high-risk population, depending on the family history with a cascade screening. If we have to go and have a look at other populations to screen, patients on dialysis with chronic renal failure or end-stage renal disease, 0.6% of the males and 0.3% of the females have Fabry disease. And there have been a number of studies in South Africa screening patients on dialysis and then embarking on cascade screening to identify other affected individuals. Left ventricular hypertrophy of unknown cause, 2% of the males, 3% of the females will have Fabry disease. And we can't really just say, the left ventricular hypertrophy is due to the hypertension related to the renal failure. Could be, but Fabry disease causes left ventricular hypertrophy. 5% of males with stroke, 2.4% of females with stroke have Fabry as the cause. And if we take young people with cryptogenic stroke, we've got a much higher incidence of Fabry disease. 4% of people with unexplained small fiber neuropathy will have Fabry disease. So those are just sort of some of the later presentations and the risks. Sorry. Okay. Prof. Hendricks spoke about the care, medical care and treatment in Fabry disease. I just want to emphasize how the multidisciplinary care that is required. Coordinated care between the main physicians, the nephrologists, neurologists, cardiologists, then the geneticists, and then don't forget about the others, the laboratories, the GP, ENT, dermatologists, ophthalmologists, to monitor the patients, optimize the treatment, ensure adequate compliance. Okay. And enzyme replacement therapy is the mainstay of treatment when it's available and suitable. Early use, as I've said, will provide the best outcome. The products that are available in South Africa are produced using recombinant technology. So they actually make a gene product that looks very much like the natural product. There are some problems related to that. If you've got less than 1% enzyme activity, introducing the enzyme as an infusion might elicit an immune response, but not always. So that's just one of the things that was spoken about last in Prof. Hendricks' talk. The other aspects of medical treatment which must not be neglected, the genetic counseling, management of proteinuria, management of hypertension, stroke prevention, and pain management. Pain management is important. And for pain management, gabapentin, carbamazepine are probably the first line treatments. And over here, I want to emphasize again, avoid opioids for the management of pain in Fabry's disease. You are just looking for more trouble if you use opioids. Hearing aids or laser therapy can also be used when necessary for the patients. So there are many other aspects that you need to think about the treatment as well. The big question is, when do we commence ERT? Males with classic disease should receive ERT by 18 years of age. Females with classic disease, as soon as signs of organ involvement appears, but before damage, as I've said. So microalbuminuria in boys should prompt consideration for initiating ERT. Or severe acroparesthesia might also be an indication to start in early childhood. I think you people can just go onto the YouTube and pause at this slide and just have a look at the details over here. But I want to go on then to another case study. This is actually a family that challenged us at a Rare Diseases Congress. It's 4 cousins that have got varying symptoms, and both of their mothers had some symptoms, but not much. So the individual 3-3 was the first one who spoke up, he had an alpha-gal value of 48.13, which is about 25% of normal. His lyso-Gl3 was 1.1, which is not really increased. He had no proteinuria, he had no cardiac involvement, but he did have tinnitus and fatigue, and he thought that his hearing was becoming impaired. But the reason that he was shouting so loudly for wanting to be given ERT was that he was a sound engineer, and that tinnitus and hearing loss would really have impacted his whole career. His brother we couldn't find his alpha-gal values. He had an EGFR of 95, but he had no proteinuria at that stage. But he also had fatigue, dyspnea, and a supraventricular dysrhythmia. Then the two cousins both had low values of alpha-gal levels. The individual 2-2 was on ERT, and he also had tinnitus, concentric hypertrophy on cardiac echo and on ECG. And at that stage, the variant that was identified in the family was considered a benign variant. If you remember on my slide of the triangle, the colorful triangle. However, since then, this variant has been identified in the descendants of one of Henderson's original patient. It was a symptomatic descendant of Henderson's original patient, and they found exactly the same variant as this family has got. And there have been other studies from the Scandinavian countries proving that this is a late onset cardiac variant. So sometimes it's difficult, and time does help us make a decision as more information becomes available. I touched on chaperone therapy earlier, and I'd just actually like to take us through this, which I find a very fascinating topic. So what happens when we've got this alpha-gal, which has got a unstable, which is unstable due to a pathogenic variant shown up as mutation over there, and that actually results in it being removed as it moves through the endoplasmic reticulum. So this alpha-gal will actually be removed and broken down through the endoplasmic reticulum. But what chaperone therapy does is it will come and bind to the active site of the enzyme, and it will literally drag it through the endoplasmic reticulum and the Golgi apparatus into the lysosomes. The chaperone then will come loose, and the enzyme will start breaking down the substrate. It only works for certain types of pathogenic variants, but where it does work, it is actually effective, and it's an oral treatment, which is obviously far more convenient than having an intravenous infusion for enzyme replacement therapy every 2 weeks. Monitoring patients and monitoring their progress, monitoring their response to therapy, I like using the main severity score. And there's a whole lot of different criteria, and you do the score, and from that you'll then be able to see if an asymptomatic person is actually progressing or not, and if there has been a response to treatment. I'm doing quite well with time, I think. Okay. So in conclusion, Fabry disease is an underdiagnosed, inherited, complex multi-system disorder, frequently missed by a range of adult physicians and pediatricians. And for that reason, we need to increase the awareness, which I'm convinced that this series of talks is doing. Treatment with enzyme replacement therapy is generally a safe and effective intervention, and early initiation is important. I'd just like to acknowledge Drs. Mehta, Grishkin and Kingma for permission to use some of their slides. And previously Sanofi Genzyme assembled an advisory board to draft local guidelines, and Gaucher, Fabry and Pompe disease guidelines in the South African context have been published. I'd like to thank you people for attending and not watching the cricket. And I'd like to open the floor then for questions.
Thank you, Bertram. Lovely talk. And like I say, different perspective. While people are starting to think about comments, as the geneticist, and I hope it's not the awkward question, can you just tell everybody a little bit about what is germline mutations, which sometimes comes up in Fabry disease as well?
Okay. Mutations or pathogenic variants, changes into our gene structure, can take place due to many different causes, and depending on when they take place, we will then have either germline or somatic variations. So the somatic means that it takes place outside of the ovaries or testes, and it might just be limited to a single organ or to a certain group of cells. Germline means that the variant was present either in the ovary or in the testes cells, and that the sperm or ovary or egg cell then carries this pathogenic variant, and from conception the baby will then have a germline mutation, meaning that they've got an inherited disease.
Wonderful, thank you. Let's see if there are any other questions at the moment. I don't see any in the Q&A. People are a little bit shy, and I don't want to ask all the awkward questions, but I will ask one more, because I do want to just ask, do you think in the South African content there is a group of Fabry patients potentially sitting in the functional F&D clinics, the functional disease? Because in Western Europe, 1 in every 5 females we see had actually a diagnosis of functional disease made earlier during their history.
I think it must be so. I mean, many of the symptoms are quite non-specific, and sometimes just the multi-system nature is not identified. And as I said with little boys, they're often called malingerers or lazy just because they've got heat intolerance, exercise intolerance. They don't want to play sport. Not that they, well, I can't say not that they don't want to, they do want to, but as soon as they play sport, they become so uncomfortable that they just avoid playing sport. So I'm sure that if we have to do a proper history and in the group of functional disease people, we will find people that have got depression due to chronic pain, and the pain could be due to Fabry. What incidence? It'll actually be an interesting study to go and have a look at that, rather than screening end-stage renal disease or cardiac clinics. I don't know how you feel, Chris.
Yeah, oh, absolutely. I think it will be a really good study to do. And I think Marley spoke a few weeks ago, you wonder if there's a utility just to do a lyso-Gb3 in one of these groups of patients, and just pick then the ones out with an abnormal value, that you don't want to start stigmatizing patients up front, but just do a kind of a biomarker approach. I'm not sure how prevalent it is in South Africa. We have a huge problem that everybody's got Lyme's disease, and we've pulled a lot of our Fabry patients out of there in the beginning, because everybody who doesn't have a diagnosis gets tagged as Lyme disease, and now it's long COVID.
Okay, yeah. And long COVID can have strokers at an early age as well.
Yes, so it just gets more and more cloudy, and at the moment we don't have very good biomarkers, at least for that, but there is definitely some biomarkers we could use in Fabry. So I think it's a little bit ahead. There's some biomarkers for long COVID, but still a little bit shaky at the moment, what I've seen.
Yeah, I haven't seen anything either.
There's a question here. The last family case that you showed with the 4 cousins just again clearly indicates how this disease presents different in each individual. Was just wondering who the index patient was here and how did you approach the family to initiate the cascade screening?
It was actually quite a difficult situation because it was actually at a rare diseases congress that these people came to us, and they were actually involved with their own individual physicians. They had researched the disease because of the various symptoms and sort of pushed their physicians to do the investigations. The one cousin was already on ERT, and so we basically just provided the information that we did have to them directly, because they just approached us after a talk and advised them what they could do to their going back to their physicians. But it was only quite a few years later that I actually picked up on the fact that the particular family variant had been identified in a descendant of Anderson's patient.
Yeah, and it highlights the problem of treating the result rather than the patient. I think we just need to be clear that when patients have got symptoms, we really do need to look, because we've had similar mutations, which has been told as benign polymorphisms, where we've actually seen quite significant and aggressive renal disease then starting late, rather than the traditional early on, but kind of mid-30s, they suddenly start developing their renal disease. And then when you biopsy them, you actually find the classical features. So I think we just need to be open-minded and trust our patients when they keep on saying things are not completely right.
Yeah, I think that's so important to listen to the patients. And I think we see that quite often from the genetics point of view. As I said, the parents of a child with a complex disease have just got so much more time to spend on the internet than we have.
But another question. Sorry, there's another question. Could a patient present with POTS disease, postural orthostatic tachycardia, also sensitivity to certain smells and sensitivity to light?
I'm at a loss. I haven't come across anything like that. I must say, if somebody comes to me with POTS, I'd be looking for Ehlers-Danlos syndrome or one of those variants or something like that as a associated genetic disease. But I can't answer that question.
I would just add then say, just remember that common things are common. So although we're focusing on rare diseases and we'd love to think they are around, don't forget about the common things. So I absolutely agree. If you've got somebody with POTS, get after the more common things first, exclude them. But then if you're still struggling to find a diagnosis, maybe this is an unusual presentation. But again, this is the one I would not pursue down the genetic line. I would most probably just do a biomarker and see if there's anything to suggest it as it, but I would make sure that other things are excluded first. It's always nice to think about rare things and try and find them, but we mustn't get caught out on the other end that we miss much more common disorders, which may have other therapies which are much more easily available. And I think if anybody wants to have a question, we can unmute you if you want to talk or give an opinion, or just remember, questions can still come afterwards. All the presentations will go onto the YouTube channel. And you've all had about 5 lectures on Fabry. I think we've got 1 more to go. So the only problem I have is that when I visit South Africa next, if I bump into any one of you, if you don't know everything about Fabry, you're going to be in serious trouble. So let me see. I don't see Ilse, I don't know if you've seen anything else. Everything I could see seems to be out, and I don't want to keep people just because we've got time. But if there are no specific questions, I just want to say thank you very much, Bertram. Really interesting. And like I said, always new perspectives. And that's what makes it so interesting, because we learn. And we also have a different group of people joining these calls every time. So please spread the word as well. And let's see more and more patients. And if you need help, remember there are lots of people locally that can help you. Don't always dash across the ocean. And also the laboratories, please use them, because they can be invaluable in helping you sort out your patients.
Yes, thank you very much, Dr. Bertram and Prof. Chris, for joining and leading this meeting this evening. I think we can then end the meeting. Thank you everyone for joining. We'll see you again next week.
Thanks very much for attendance. Thanks very much, Chris, for hosting.
Thank you, everybody.
Thanks. Good night.
Good night.